The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast, where we take apart the complex machinery of healthcare policy, politics, and economics. My name is Marc Ryan, and thanks to everyone for listening in. Today's episode is titled Reports of Medicare Advantage's Death Are Greatly Exaggerated. And yes, the title is a deliberate nod to Mark Twain's famous line after newspapers mistakenly reported he had died. Because if you listen to many critics in Washington, read certain academic studies, or scan headlines in the mainstream press, you might think Medicare Advantage is collapsing under its own weight of unaccountability. But is it? Or are we seeing something different, a program going through a painful but necessary correction? We'll take our usual 3 breaks to make this a bit more digestible along the way, so let's get right into it. Let's start with a bit of history. Medicare Advantage, often called MA, technically turned 25 years old recently. The program was created by the Balanced Budget Act of 1997, with coverage beginning in 2000. It built on earlier experiments like Medicare Plus Choice and other private plan demonstrations. But MA was supposed to be different. It was designed as a public-private partnership. The federal government provides Medicare benefits, but private insurers deliver the care using managed care principles. And for years, the program grew rapidly. Today, a majority of Medicare beneficiaries are enrolled in MA plans, but the last 2 years have been very rough for the plans. In fact, if you talk to insurance executives privately, many will tell you 25 and 26 were among the toughest years the industry has faced since the program began. So what happened? A lot happened. First, the administration pushed major prior authorization reforms, demanding faster decisions, better transparency, and limits on how plans could use prior approval for services. Second, the government proposed an aggressive risk adjustment data validation program, RADV, designed to recover billions of dollars in alleged overpayments. The proposal would subject every contract and every payment year to targeted audits. That's a huge compliance and financial risk for plans. Third, regulators proposed sweeping changes to the Medicare Advantage star rating system, the quality program that determines bonus payments. Many easy-to-achieve measures would be eliminated. The health equity bonus program would disappear, and projections suggest as many as 25% of plans could lose a half-star rating by 2029. That matters enormously because star ratings translate directly into billions in bonus payments and marketing advantages. Then there's the money. The administration did finalize a 26 rate increase of just over 5% for 26 again, but early projections for 27 rates are essentially flat. Now that could change a little bit, but it still will not be as generous as 26. Flat rates may not sound dramatic, but in healthcare economics, where costs typically rise 5 to 8% annually right now, flat rates effectively mean cuts. And regulators went further. They announced additional risk adjustments beyond the already controversial V28 model that took a great deal out of rates from 24 to 26. One particularly significant change for 27 would be that plans would no longer be able to receive risk adjustment credit from unlinked chart reviews that are not tied to actual medical encounters. That may sound technical, but it hits directly at how plans document patient diagnoses and how they get paid. In other words, future revenue streams for MA plans are being squeezed from multiple directions. Higher utilization, regulatory tightening, risk adjustment reforms, and uncertain future rates. All of it limits the ability of insurers to use managed care tools to control costs, and the fallout is already visible. Actuarial firm Milliman reports that the average value added by Medicare Advantage plans declined more than 8% between 2025 and 2026. That's the largest drop since the program began. Consulting firm Wakely reports something similar. Average member premiums rose from $12 per month in 25 to almost $15 in 2026. At the same time, plan value add declined about 11%. Dual eligible plans, the ones serving the poorest and sickest Medicare beneficiaries, saw smaller declines, but declines nonetheless. In response, insurers have been retrenching. What do I mean by that? Well, they've cut supplemental benefits, they've exited markets, they've discontinued certain products, and they've pulled back geographically. All signs of an industry trying to stabilize financially after several years of overexpansion. But the real question is this: is this a temporary correction, or is it the beginning of a structural collapse of Medicare Advantage? Before we answer that question, let's take our first break, and when we come back, we'll continue on what is happening in MA in 26 with some looks at that data. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and thanks for listening to the Healthcare Labyrinth Podcast. We're discussing the turbulence surrounding Medicare Advantage and whether the program is actually in decline. We are talking about MA's future and why its death, like Mark Twain's, was greatly exaggerated. Let's get to part two, the data behind the panic. Let's look at the numbers. In 2026, Medicare Advantage enrollment grew just 2.5%. That may sound healthy, but compared to the double-digit growth rates of the past, it represents a dramatic slowdown. Even against 2025, growth is much lower. In 25, growth had slowed already to 4.4%. And for the first time, 7 states actually saw MA enrollment decline in 2026, largely because insurers exited those markets. Meanwhile, something else happened that hadn't occurred in years. Enrollment in traditional Medicare, fee-for-service Medicare, grew by about 600,000 beneficiaries. That reversed a long-term trend to decline. So some people are clearly reconsidering their options. But here's the important context. Even in a difficult year, Medicare Advantage still grew from 25 to 26 by almost 900,000 people. In other words, the program continued to expand, just at a slower pace. And that tells us something important. Even with fewer benefits and rising premiums, many seniors still see Medicare Advantage as more attractive than traditional Medicare. Why? Because traditional Medicare leaves beneficiaries exposed to unlimited out-of-pocket costs unless they buy supplemental coverage like Medigap. And those policies are often expensive or unavailable for lower-income seniors. So despite the turbulence, MA remains financially attractive for many beneficiaries. But insurers themselves are clearly worried. One industry survey found that 69% of Medicare Advantage executives expect their enrollment to remain flat or decline even in 2027. Nearly 70% expect to reduce benefits next year. Yet, interestingly, those same executives do not expect a negative 5-year outlook. That's an important signal. The industry thinks the current pain is temporary, but it also reflects something else. Some of the challenges we're seeing today are self-inflicted. During the boom years of Medicare Advantage growth, many insurers behaved like tech startups chasing market share. They launched generous supplemental benefits. They expanded PPO products across the country. Those are very expensive. They entered new geographic markets that may not have had margins, and investors rewarded them for enrollment growth rather than financial discipline. In hindsight, Much of that expansion was never financially sustainable. Now the bill is coming due. Plans are retrenching. Benefits are shrinking back to the norm. Markets are consolidating. And insurers are rediscovering something fundamental. Healthcare is not a Silicon Valley growth experiment. It is a highly regulated, thin margin public program. But even in the middle of this correction, some indicators are actually quite positive. For example, smaller and regional insurers are stepping in where national plans are retreating. During the most recent enrollment cycle, regional plans grew by about 443,000 members, while large plans contracted by roughly 328,000. That suggests competition is evolving rather than disappearing. Another positive sign is the growth of special needs plans or SNPs. These plans focus on vulnerable populations such as dual eligible beneficiaries who qualify for both Medicare and Medicaid. SNP enrollment grew 647,000 year over year. These plans often serve people with multiple chronic conditions and significant social needs, so their expansion arguably represents a strengthening of Medicare Advantage's safety net role. Still, critics argue the entire program is fundamentally flawed, and the biggest argument they make revolves around one issue: overpayments. So let's tackle that next after our second break. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and thanks for listening to the Healthcare Labyrinth Podcast. We're discussing the turbulence surrounding Medicare Advantage and whether the program is actually in decline. We're talking about MA's future and why its death, like Mark Twain's, was greatly exaggerated. We promised to tackle the issue of overpayments, so this is it. Part 3, the overpayment narrative. If you want to understand the political fight around Medicare Advantage right now, you have to understand the overpayment debate. For years, the Medicare Payment Advisory Commission, MedPAC, along with many academics and policy advocates, have argued that Medicare Advantage plans are systematically overpaid compared with traditional Medicare. Some analyses claim those overpayments still exceed 14%, but if you read the news, there's even higher percentages from previous years quoted. Those numbers have driven major policy proposals in Washington. They've been repeated in media coverage continually again, and they fueled the narrative that Medicare Advantage is essentially a massive subsidy to private insurers. But there's a problem. The numbers are increasingly out of date and the analyses flawed. Back in 2024, the Centers for Medicare and Medicaid Services began implementing a major reform to the risk adjustment system known as the V28 model. Now, plans hated this, but in retrospect, it's probably a positive thing for them, despite some of the financial impacts. Risk adjustment is the mechanism used to pay Medicare Advantage plans based on how sick their members are. The idea is simple. Plans that enroll sicker patients should receive higher payments. But critics have long argued insurers exploit the system by aggressively documenting diagnoses, a practice sometimes called upcoding. The V28 model attempts to fix that. It eliminates many diagnosis codes that previously generated additional payments. It changes the weighting of certain conditions, and it reduces the financial impact of diagnoses that may not truly drive healthcare costs. The result? A major reduction in estimated overpayments. After coding intensity adjustments in the rate system, the estimated excess dropped from roughly 10% to about 4% for risk adjustment over coding. In fact, CMS analyses suggest that true structural overpayment now may be closer to just 2%. That's a huge shift. Yet many critics continue citing a number derived from the pre-V28 system, and even MedPAC has quietly begun to revise part of its analysis. Today, again, its estimate of the 14% overpayment it sees in the system now breaks out between about 10% from favorable selection assumptions, essentially the claims that healthier people choose Medicare Advantage. I've argued for years this is nonsense, and plenty of studies show that MA serves more vulnerable seniors and disabled than fee-for-service. But the favorable selection number has always been part of MedPAC's political narrative. The other part of the 14% overall overpayment, according to MedPAC, is the 4% that remains from risk adjustment coding intensity. That's a decline from 10% in the past, as I noted. The fact is, MedPAC's underlying data actually show MA is paid at or below fee-for-service. I do not dismiss that there was some overpayment on the risk adjustment side, and that seems to have been dealt with in the V28 reforms we discussed and the coming changes for 27. But it is also important to note that the overpayment that did exist was rather concentrated. It went to a subset of plans, usually big ones. MedPAC and other academics really never mentioned this. A study by the Alliance of Community Health Plans, which represents nonprofit regional insurers, found something striking. The largest national MA insurer, UnitedHealthcare, collected up to $785 more per beneficiary in 23 than nonprofit plans. That translated into more than $6 billion in additional payments that year. The second largest insurer, Humana, collected about $423 more per beneficiary, representing roughly $4 billion more than nonprofit plans. And the risk scores tell a story. UnitedHealthcare's risk scores were 36% higher than those of nonprofit plans. Humana's were 19% higher. Earlier research estimated $14 billion in excess payments to UnitedHealthcare alone in 2021. Another study published in Health Affairs examined the use of health risk assessments conducted in patients' homes. These visits often generate additional diagnoses that increase payments, even if the conditions are not treated in subsequent medical encounters. The HHS Office of Inspector General found that diagnoses reported only through these assessments generated about $2.6 billion in extra payments. When combined with chart reviews, the potential overpayment rose to about $9.2 billion. But here's the key point. Only 20 out of 162 Medicare Advantage plans accounted for more than half of those payments. One company alone accounted for 40%. In other words, a small number of aggressive players, largely large ones, may be driving the entire overpayment narrative, which raises an obvious policy question. Should regulators punish the entire program, or should they focus enforcement on the plans actually abusing the system? Before we wrap up, one final break. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and thanks for listening to the Healthcare Labyrinth podcast. We're discussing the turbulence surrounding Medicare Advantage and whether the program is actually in decline. We're talking about MA's future and why its death, like Mark Twain's, was greatly exaggerated. On to part 4, why Medicare Advantage isn't going anywhere. Despite the turbulence we've discussed, there are strong reasons to believe Medicare Advantage is not collapsing. In fact, its long-term future may still be quite strong, as long as Capitol Hill and CMS do not overreact to flawed analyses out there. And interestingly, some of that argument is now coming from unexpected voices. Earlier this year, two former secretaries of Health and Human Services, Donna Shalala, who served under Democratic President Bill Clinton, and Tommy Thompson, who served under Republican President George W. Bush, published a joint opinion piece. That duo had a powerful argument. Think about that for a moment. A Democratic HHS secretary and a Republican HHS secretary writing together in defense of Medicare Advantage. Their argument was blunt. They noted that while regulators claim Medicare Advantage remains stable because premiums are low, the reality for beneficiaries has looked very differently the past couple of years. Billions of seniors have lost plans, supplemental benefits are shrinking, out-of-pocket costs are rising, and the changes are not affecting all regions equally. In 26 alone, they note that about 2.6 million seniors saw their MA plans discontinued. That's double the number from the previous year. Shalala and Thompson also made another critical point. Medicare Advantage provides an important financial lifeline for seniors who could not afford expensive Medigap policies or the 20% cost sharing required in traditional Medicare. As we know, MA fills in a lot of those gaps. Without MA, many of these seniors would face significant financial risk. The former secretaries also criticized MedPAC's methodology, arguing that its calculations rely on apples to oranges comparisons and incomplete data. They cite a great Healthcare Leadership Council report in late 25 that ripped apart MedPAC's arguments on both overpayment and favorable selection. And they warn that policy decisions based on these flawed and back-in-time analyses could undermine a program that millions of Americans rely on. I would note that Capitol Hill just did this again, though, relying on the MedPAC analysis to declare war on Medicare Advantage. The bipartisan Congressional Joint Economic Committee just concluded that overpaying for Medicare Advantage plans caused Medicare Part B premiums to rise across the board for people both in MA and in the traditional program. It says the overpayments caused standard monthly Medicare Part B premiums to go from $185 a month in 2025 to $203 a month in 2026. The report from the JEC urged action. Quote, today, between aggressive upcoding, questionable quality bonuses, and structural overpayments in Medicare Advantage, seniors who stay in traditional Medicare are effectively subsidizing the system. That's not sustainable. It's not fair, and it can be reformed, said Chair Rep. David Schweikert, Republican of Arizona. That could lead to legislation, again based on erroneous analyses from MedPAC, which itself relies on other erroneous academic analyses, including on its favorable selection number. Thompson's and Shalala's conclusion was straightforward. Yes, policymakers should address fraud, waste, and abuse, but they should not dismantle a program that improves care coordination, encourages value-based payment, and serves vulnerable populations. Those bad academic political narratives are driving changes and will drive more. Some changes were merited, in my view, but perhaps too quick, while others will further destabilize things. And that brings us back to where we started. Yes, Medicare Advantage is going through a difficult period. Yes, some reforms are justified. Yes, some insurers clearly push the system too far. But none of that means the program itself is failing. In fact, what we may be witnessing is a rebalancing. Risk adjustment reforms are reducing incentives for aggressive coding. Regional insurers are gaining ground. Special needs plans are expanding. And policymakers, hopefully, are beginning to recognize that Medicare Advantage is now central to the Medicare program itself. The Thompson and Shalala piece was important, but bad stats still influence the policy debate. The industry must drive home the truth to lawmakers and CMS. Use Thompson and Shalala as well as the HLC analysis to drive home the points. The real challenge going forward will be finding the right balance. Protect taxpayers, prevent abuse, but preserve a program that millions of seniors prefer. Because when you look at the full picture of MA, one thing becomes clear. To borrow again from Mark Twain, the reports of Medicare Advantage's death are greatly exaggerated. Thanks for listening to the Healthcare Labyrinth Podcast. If you enjoyed today's episode, be sure to subscribe and share it with colleagues interested in healthcare policy and the future of Medicare. Until next time, stay curious, stay skeptical, and keep navigating the Healthcare Labyrinth. Again, I am Marc Ryan. This is the Healthcare Labyrinth Podcast. See you next week. Take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.